everyone, it's Dr. Towfigh. How are you? Welcome to Hernia Talk Live. I am your host, Dr. Shirin Towfigh, hernia and laparoscopic surgery specialist. And I'm super excited to be with you today because it's another beautiful Tuesday. We used to call it Hernia Talk Tuesdays. Um, we're we're switching it up a little bit. Some of you are joining me as a Facebook Live on my Beverly Hills Hernia Center page. As you know, I run the Beverly Hills Hernia Center, and it's, according to me, the absolute best hernia center in the world. I would say we are experts. We are amazing at what we do, and everything we do every day is to make you better from a hernia or hernia-related standpoint. So thank you to everyone who follows me on Beverly Hills Hernia Center on my Facebook page, but as you know, I also have my own Facebook page at Dr. Towfigh. If you like to hear about academic stuff, you can go on my Twitter page at HerniaTalk. That's really mostly for my doctor audience. And we always have fun on Instagram at HerniaTalk as well. Remember, this episode and all prior episodes, all 202 episodes will be are accessible on my YouTube channel, or if you like to listen to Hernia Talk Live as a podcast, that's also available to you, which I think is really cool. I listen to it sometimes myself, actually. I try and listen to see how it sounds like as a podcast because I personally love podcasts. Um, I'm listening to one right now. It's on the Indian Cricket League, which I didn't know much about, but I was talking with some of my friends in London. As you recall, I was in London last month, and I was watching Wimbledon, so I kind of sent a shout out to them. And one of them said, "Oh, I'm watching the Indian Cricket League." I'm like, "What? During Wimbledon? That makes no sense." But then I saw this podcast on it, so I'm listening about it, trying to learn more. Apparently, it's a big deal. Fun fact, second only to the NFL, the greatest amount of advertising money is spent for the Indian Cricket League. Different than the British Cricket League, by the way. So rules are a little bit different. Anyway, we're talking about hernias. So for those of you that follow me, you know that I tend to pick my topics based on something that happened that week or a patient that came to see me or something like that. And this week's topic is called hernias and non-believers, and I'll help explain to you. So you know the term believers, and as I have progressed in my hernia world, hernia expertise, as I become more popular and well respected in this field, I started using the term believers, and I would say, "Oh, he's a believer, she's a believer." It's kind of similar to like the Justin Bieber followers who are believers. Well, these are hernia believers, and that is that people understand, people who understand that it's not just a hernia, that a hernia is beyond just being a hole with a bulge, uh, etc. I would say that there's been um, kind of disregard for hernias for centuries because it's always considered a male disease. And if you didn't have a bulge, and if it was painless, we would consider it a hernia. But I'm sorry, if you had a bulge and it was painless, it was considered a hernia. It used to be taught if it hurts, it's not a hernia. It must be some other disease process. Or if there's no bulge, there's no hernia. All of that is incorrect, by the way. You can have a hernia with a bulge or without a bulge. You can have a hernia that has pain and doesn't have pain. The fact that the pain is intermittent or sometimes occurs and doesn't occur, or you didn't have pain before, but now you have pain, is completely irrelevant. It can still all be a hernia. So, the point is that the people that do believe it, the people that do agree that atypical symptoms can occur with hernias, that small size hernias are just as relevant as large size hernias. In fact, sometimes more important because they're more likely to incarcerate or strangulate and more likely to cause pain and symptoms than the larger hernias. People who are believers are the ones that I call believers. But then that implies that there are non-believers. And I had to deal with non-believers this past week. It made me angry. It made me frustrated because no matter how many times I would explain to them, they were clearly not, and by they I mean doctors, they were clearly not agreeable to relearn what was taught to them 50 years ago when they were in medical school. So the situation goes like this. You have a patient that chose to see you for whatever reason. It could be they're referred to you by a doctor or colleague, or maybe a patient of yours referred them to you, or the patient did their own research online, social media, AI, whatever, and they said, go see Towfigh because you may have a hernia or she can help figure it out for you. They see me, I do a full workup. I'm not someone that like stands across a table and says, aha, hernia, let's go fix it. A, I have to diagnose you with a hernia. B, that includes oftentimes a very thorough story. And your story is very important. Many of you who follow me know how important it is that you have the right story, right? So if you're telling me your ear hurts and I have this bulge, I'm not going to say, okay, let's fix the hernia. I'm going to say, let's see why your ear hurts. And therefore, if your story doesn't match that for a hernia, I start looking for other causes of pain or symptoms. Physical exam is very important, and we know, you know, because you've been listening to me, that not all hernias are the same. Some hernias have an obvious bulge. Some hernias don't have a bulge. Some of them are very tender on exam. Others may not be tender on exam. You can have hernias on both sides. There's different types of hernias. Different parts of the body can have hernias. Certain parts of the body can never have hernias. And so to call an area painful because of a hernia is not correct. So physical exam is very important. If you need imaging, imaging is important. Again, those of you that follow me know that imaging is often misread by radiologists, both ultrasound, CT scan, and MRI. We've published on this. 3 out of 4 CAT scans are misread for hernias. So that's just a horrible statistic, which means that if you go to a doctor and they get a CAT scan and there's no sign of a hernia based on the radiology report, 75% of the time, that may be incorrect. And therefore, they come to me, I look at the imaging myself and I'm like, look at, here's a hernia. So now I have to convince another doctor who never looked at the imaging themselves, never knew how to read an imaging themselves, who's trusting the radiologist who wasn't skilled enough to understand what a hernia may look like on imaging, and believes the non-specialist radiologist over the specialist hernia surgeon in imaging. So, and then lastly, I have to take your story, your physical exam, and your imaging, put it together and say, you have a hernia, yes or no, A, and then B, the hernia is the cause of your symptoms and therefore surgery for it will help. Or you don't have symptoms and watchful waiting is helpful. But the purpose is those two have to be equal. You have to have the findings and symptoms that can be attributed to it for me to recommend hernia care of some sort, whether it's surgery or otherwise. And then that will be my plan. So today, for example, I saw a young, healthy, active, fit gentleman who wears a belt for work, and when bending down felt like this ripping, tearing sensation, and was like, uh-oh. So he then noticed what he thought was a bulge and went to a doctor, and doctor said, maybe you have a hernia, go to a surgeon, saw a surgeon, surgeon offered him surgery. So he says, what are we operating on? He's like, I mean, I don't know, maybe you can have a hernia. He says, what do you mean, maybe? Do I have a hernia? And the surgeon says, I don't know, we can find out. So I don't work that way. There's no way I would just, without any workup, just say, you know what, we'll operate on you, and whatever we find, we'll figure it out. And if we don't find anything, then you never had a hernia. Like that's not appropriate in my view. So of course the patient also thought, maybe that's not the right approach. So he came to see me. And guess what? Yes, he did have a hernia, but that wasn't the cause of his pain. He had a muscle strain that causes pain. The bulging had nothing to do with a hernia. He had bled from the muscle tearing, and he had a little blood clot, like clotted blood and swelling, which then eventually went away after his own body resorbed it. So, long story short, this patient that was being whisked off to surgery immediately by another surgeon, I did not offer surgery to him. I offered him an injection, physical therapy, rest, anti-inflammatories, typical things for a muscle strain, and told him to ignore his hernias because they're small, asymptomatic, and he's otherwise fit and healthy, so he should do fine without need for surgery anytime soon. So that's the way I work. So when I get a patient who's had years of pain, years of being given narcotics, by the way, years of allowing him to be now depressed, years of him being at times suicidal, and I very carefully figure out that the cause of his pain, part of it, not all of it, part of it are these hernias. Um, and I offer hernia surgery. It really irks me when a doctor who has no expertise in hernias, doesn't know any other surgeon that has expertise in hernias, is blocking me from helping this patient, blocking me from helping this patient, while at the same time giving zero alternative options to help this patient. And I like to have buy-in by the patient's doctor. I don't want to operate on a patient without their medical doctor, being part of the decision making. The patient was okay with it. The patient understood. I showed him the imaging, showed the hernia. I showed him, I went through all the different symptoms of hernias. He has many of them. I showed him on examination where I feel the hernia. He agreed. We had a plan. And then later on, what happens, the doctor, all he does is, hernias shouldn't hurt that much. Yes, they do. He doesn't have a big hernia. No, he doesn't, but he does have one. Imaging doesn't show hernia. Yes, it does. Well, I showed this to 5 other surgeons, and that I saw sitting at this table, and all of them said it's not a hernia. Well, those are not hernia expert surgeons. Well, I went to a radiologist and showed the imaging, and they don't see a hernia because they're wrong. They're not hernia specialists or imaging specialists for hernias. So the fact that most doctors, most doctors do not understand that hernias can have symptoms that aren't classic, right? So we know for the belly, you can have bloating, you can have pain radiating to your back. That's not taught in textbooks. You can have pain to the side of the belly button and not have it at the belly button, and can still be a belly button related hernia pain. For the groin, you have pain that radiates into your testicle, inner thigh, around your lower back. You can have bloating. You can have urinary frequency. How is that related to a hernia? Well, those of you that know, pelvic floor spasm can be a complication of inguinal hernias, and all those symptoms. Clitoral pain can be due to a hernia. Penile tip pain can be due to inguinal hernia. We discussed that last week. Rectal pain, coccygeal pain, all of those can be due to pelvic floor spasm related to inguinal hernias. pain with defecation, pain with sexual intercourse, pain on even erectile dysfunction can be due to an inguinal hernia. So all of these are atypical symptoms, which when you spend time with a patient and ask the global picture questions and key questions that are high yield, which one day I'll kind of review those for you. And they say yes, 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 yes to all of those. And the physical exam is suggestive of a hernia, and the imaging shows hernias. Well, then in that case, you have a situation where it's a hernia, unless you have a non-believer. And the non-believer is it has to be a big bulging hernia and it can't be painful. And that's how it was taught. I literally went to my very first American Hernia Society meeting. These are hernia specialists, by the way, but they were all men and they were all older men and they were all interested in your typical hernias. And they literally, after I got involved with the American Hernia Society, over the next 3 to 5 years, I would sit on panels and they would say, and I quote, if it hurts, it's not a hernia. Literally, they would say, if the groin pain is severe, gotta look for another reason for it. It can't be a hernia. And I was so junior. These are like people in their 70s, 60s, 70s, and I was like maybe mid-30s, mid to early to mid-30s. And I was ballsy back then. I was sitting on the same panel as them. So I didn't feel intimidated by the fact that these are the gods of hernias spewing out information that I didn't believe in and that I thought was incorrect. And they're telling it to an audience of surgeons that are listening. They're then going to go back and take that information that they learned from the conference to their office. I said, I respectfully disagree. It is quite natural for hernias to be pinched and hurt, for them to be very painful in women, etc. And they said, well, no, we recommend, hernias in general should not be painful. Completely incorrect. Why do you have a watchful waiting trial that only includes patients without pain, implying that the exclusion criteria is patients with pain? And the whole premise is once you get pain, then you have indication for hernia surgery, but watchful waiting is safe when you don't have pain. Doesn't that imply that hernias hurt? It didn't make any sense to me back then. And the older doctors and some of the younger ones, mostly it's the older ones, nowadays are spewing the same information. So now you have a patient who will not be referred to someone like me, or when they are referred to someone like me, I'm telling them let's do surgery, and they're going back to their doctor saying, I'm not approving surgery. I don't think it's the right thing. I think you're making a mistake. And what do? They bring in all the back, all the what's the right term? Uh, not luggage, not baggage. Baggage, I guess. From look at all these people with chronic pain after hernias. Look at all this mesh complications. And they scare the patient away from having the surgery that they need because they themselves are a non-believer and they're importing their bias onto the patient, scaring the patient from getting the care that they need. Here's a question. Can muscle guarding or stomach bloating hide a hernia during imaging? No, it cannot. So in general, the hernia as a defect is always there. And even if you're not having content go through it, push through it, such as with a Valsalva, bear down views, coughing, whatever, there's usually a content in it anyway, like a little bit of fat that you may not know. So when hernias, quote, reduce, they're not always empty. The sac may still be there, remnants of the hernia, such as fat, may still be there. So it is better to get imaging with pushing out of the belly because that can make the hernia look bigger, But if you don't, it doesn't mean necessarily that you don't see the hernia. With one major exception, and that's direct inguinal hernias. With a direct inguinal hernia, when you do the Valsalva, because it's not an actual hole with a punched out hole with content in it, it's usually a weakness. So when you're lying flat, that weakness flattens out. And then if you're lying flat and pushing out, then it'll bulge out. It's called the Mickey Mouse sign. If you have a bilateral left and right inguinal hernias that are direct inguinal hernias and you push out, these are called the Mickey Mouse sign because you kind of get the Mickey Mouse. And in some patients, the bladder actually goes into it. That's a very classic Mickey Mouse sign, which is when the bladder falls into left and right direct inguinal hernias. In fact, I had one doctor, again, staying on topic about the non-believers, who told me the patient does not have hernias because the imaging didn't show it. I had to remind him that imaging is only a supporter of the clinical diagnosis. Hernias are a clinical diagnosis. We don't operate on people that only have imaging results with a few exceptions. Femoral hernia being one of them. But in general, uh, you have to have symptoms and you have to have an exam finding of some sort before we commit you to surgery. Imaging is just there to support any suspicion or plan for your surgery, etc. So the fact that you're arguing with me already about a patient who clearly has hernias on exam and by symptoms because the imaging didn't show it is complete BS, because imaging doesn't trump physical exam and symptoms, number one. Number two, this other non-believer we're talking about here didn't know what a direct hernia is or indirect hernia is. Those of you that follow me know the difference. Indirect hernia in the groin is a very common punched out hole, often with fat through it, sometimes intestine if it's large enough, sometimes bladder infrequently. A direct inguinal hernia is medial, so inwards from that, also in the groin. That is usually not a punched out hole. It's usually a thinning and stretching out of a layer of muscle called the transversalis fascia. When that happens, when you stand, it bulges out. When you lie flat, it goes flat because it's just a weakness. It's like the way I describe it is like when you wear sweatpants for a long time and the knee starts to stretch out. That's what a direct inguinal hernia is. So if you look at imaging, the radiologist often does not call a direct inguinal hernia, only calls an indirect inguinal hernia because the direct hernia in their eyes is not a hernia because they don't know about it, but mostly because it's not a hole with something going through it. It's just a thinning. So then the same non-believer calls me and says, "No, I reread the imaging with the radiologist, and they said there's no hernia. There's, quote, just a thinning of the fascia with fat protruding into it." You just described a direct inguinal hernia. What do you mean there's no hernia? So this is what drove me nuts last week, is when I had to deal with these hernia non-believers, and they're like an obstructionist wall. All they've heard about is hernia repair's gone bad, mesh gone bad, and therefore, what is their idea? Like everyone with hernia should never get surgery ever? I mean, this guy, one of them, ones that I was dealing with, the patient has had chronic pain for years, and I'm offering a solution. And I'm not just like some random Joe Schmo. Maybe he thought I was. Maybe he didn't know who I was. I don't know. He should know because we've shared patients before. But I don't know. It just I feel like sometimes HerniaTalk Live is just a way for me to vent a little bit because you all get me and you understand me, and many of you have suffered through the same situations and stories, and hopefully you understand. And many of you have had doctors that are hernia non-believers. They're non-believers. They don't think you have the right hernia. I've had patients drive down from Canada for days to come to see me against the will of their medical doctor because the medical doctor said, "You don't have hernias. You're just going to go down there and quote Beverly Hills and you're going to see this quack doctor, which is what they were told. She's going to, quote, take your money and maim you, which of course is not correct. And of course, I didn't take it personally, but how horrible for a doctor to do that. Of course, I diagnosed the patient correctly. They got their hernia repaired. First time ever that they were pain-free, to the point where the patient was driven by, I don't know if it was boyfriend or husband, from way, way up north in the upper province, one of the upper provinces in Canada, all the way down south to California. And she was in so much pain through the drive. She was in the back of the car, like on the passengers, lying flat because of the pain. And driving back up, no pain driving back up. We're able to pit stop here and there to like enjoy the scenery and have a lunch or something. So all delayed because she had a doctor that didn't believe. Non-believer. Okay, yeah, let's go through your questions again. If a direct hernia is not causing the defect, how does it cause pain and how can it lead to strangulation? Good question. So direct hernias usually do not lead to strangulation. I always explain to my patients that of all the hernias, it's one of the more kind of quote safe hernias because you see the bulging. The bulging can usually cause not severe pain, but like a dull aching pain. Some people describe it as a heaviness. It's like having like a sack of water hanging. So that's usually the type of symptoms of a direct hernia. If it gets very big, it can follow the same trajectory down with the indirect hernia that goes down to the scrotum. Those would be really big. And so that if it stretches out so far out that it's essentially like a punched out hole then, because it's so thinned out, the neck of the hernia can cause obstruction. That's very uncommon in the first world, maybe more common in a situation where people don't get access to care. Can a small umbilical hernia, asymptomatic, be repaired during the same laparoscopic TEP surgery for bilateral inguinal hernias? Absolutely. If so, hold on. If so, will the umbilical hernia also be repaired with mesh? Unlikely. Unlikely. So I actually offer this very commonly. Because patients either know or don't know that they have an umbilical hernia, but they are seeing me for their inguinal hernia. And when they do so, I diagnose them with an umbilical hernia. I'm like, hey, you have an outie. Did you know that? Oh, I didn't know that. Or yeah, it's been bothering me, whatever the situation is. And then I offer repair because I still need an incision. I still need to do an incision in the belly button for the laparoscopic repair. So why not use that? Getting like a coughing, not sure why. So I can still get access to the belly button in that incision for the tap to fix the hernia repair. Fix the umbilical hernia repair. Yeah. So yeah, totally doable. Usually those are small hernias, less than 1 centimeter, and they do not need mesh repair. Infrequently, they do need mesh if it's 2 centimeters or more, or if they are high risk patients and it's between 1 to 2 centimeters. And you can I have at least one episode where I talk only about umbilical and ventral hernias and we go through the algorithm for that. But basically, it's great to be able to, do a laparoscopic repair, and if there's a hernia at the belly button, use the incision for the laparoscopic repair to also gain access to the belly button to get it done, to get it repaired. All right. Sorry for all the coughing, you guys. I'm so sorry. So let's see, we had some questions submitted as well this time. Actually, almost every week, but often we don't get time for it. So when should you seek consultation with an expert hernia surgeon after other doctors dismiss your symptoms as not hernia related? Well, I would say nowadays, that's a very easy question because social media, AI, those are all great resources, with the web, those are all great resources to look at, uh, to do your research, right? There was an ability to do research back then. Everyone would just go to like Mayo Clinic or something, or they would ask their neighbor or ask their friend. It was like a referral base. But uh, you should do your own research. We are really good right now at being our own patient advocate. I have patients from all over the world. We had Singapore, Malaysia, multiple Middle Eastern countries, South Africa, Algeria, a lot of the South American countries, Canary Islands, Jersey. Do you guys know where Jersey is? Pretty cool place. A beautiful island in the English Channel, I think. It's it's kind of British, but not true. It's not part of the United Kingdom. Um, Russia even. Um, they do research the same way you do research. Their web access is the same as your web access if you're in I'm talking about you as in the United States. And so you can do your own research. I offer online consultations, so you don't even have to fly in to see me. If you want to just run your situation by me, you can say, listen, I have a non-believer, but every time I do my own research, it shows that I probably have a hernia. Or I read an article by you and I felt like I was reading about myself. Everything this patient was going through, I'm going through. These symptoms, I have those symptoms. So researching and being your own patient advocate is great. And many of us, Cleveland Clinic, I think, does the same. I'm not sure. Offer online consultation. So you basically contact my office, send in all your information. Some people send in pictures of themselves, then they mark on the picture where their pain is. Um, some people send drawings of where their pain is. I love getting like a full diary of kind of your symptoms and kind of overview of things. I must have any imaging that you've had. I want to see the prior notes and reports and all that. We have our own hernia health questionnaire, which is kind of a detailed questionnaire asking very key, high yield questions. So you go through all of those, send them to me. Then when I'm not working in the office, usually on a weekend or at night, because I have no life, um, I'll review that and send you an email. So if you get an email from me like on a Sunday night, um, like don't be surprised. That's often when I do my online consultations. So I enjoy that. It's like a little puzzle. How many of you guys do the New York Times puzzle? So you know how there's the Wordle, right? Like Wordle, but there's also uh what's it called? I'm blanking on it. I just did one today. Is it called the one with the four groups? Oh, connections. There's connections, right? Very difficult. Usually the last one or the second to last one is very difficult. Or strands, where gotta look for the hidden words. Like I love doing that stuff. So when I get an online consultation, I've got multiple on my desk right now. One with a big yellow sign that says expedite, please. So you know who you are if you ask for expedition of your online consult. Um, I usually take those home and I work on them. So if I don't have you to talk about and work, then I do a Wordle or two. So, that's how I roll. Where were we? Let's see. Question. Okay, question. With regards to the symptoms and findings you're talking about today, what clinical history, physical examination, and other tools can be used to differentiate pain originating from a pubic plate disruption, athletic pubalgia, from that coming from either a direct or indirect hernia in patient diagnosed with both conditions, but in whom the hernia defect may be an asymptomatic result of the same athletic injury. So inguinal hernias are usually not a result of athletic injury. Athletic injury is more common with a tear. It's usually not an inguinal hernia, although there is something called a Gilbert's hernia, which is really usually not even a sports injury. So, and in order to have an athletic injury, you have to be an athlete. So if you are not an athlete, it's unlikely you'll ever get an athletic injury. The physical exam findings are definitely different. Like the patient that I saw earlier today, he has point tenderness on his pubic bone where the rectus muscle attaches and can't do a sit-up. When I press on it, he was like yelping in pain. Whereas his inguinal canal area was not tender at all and had no bulging at all. He also had imaging findings, which shows some swelling in the area of the rectus muscle insertion onto the bone. You can have a tear of your fascia, in which case a nerve may go through it. You can have nerve pain, and physical exam will be pretty much normal, and imaging will also be normal. If your pain is often activity related and pain goes away when you're lying flat, that's usually a hernia and not a sports injury. If the pain radiates the thigh, inner thigh, or the testicle around your lower back, that's usually a hernia related and not a sports injury. And sports injuries will tend to respond to injections, whereas hernias will tend to be more painful after an injection. So there's all these little nuances, but it's really that trifecta of triple concordance, right? So story, physical exam, and imaging, all three kind of supporting the same diagnosis and not being thwarted by one finding versus the other. So let's say you have a hernia on imaging, doesn't mean your pain is from imaging like we saw in this patient that I saw earlier today. Next question. What kind of hernias or associated complications present the most complex differential diagnosis? So good question. I would say two types. One would be the the uh, the rare ones, right? And next week we're going to talk about rare hernias. If you have a rare hernia, most people will not be thinking about that in your differential diagnosis. I just repaired my second sciatic notch hernia. Sciatic notch hernias are the most rare hernia you will ever see of any hernia. It's a very rare pelvic hernia. Most people don't even know what it is. And therefore, like a radiologist would not necessarily know to look for it or find it or diagnose it. A neurosurgeon may see someone with sciatic pain or a spine surgeon or a pain management doctor and treat them as was for sciatic pain, where truly it's a sciatic notch hernia, where the hernia is irritating the sciatic nerve, causing the sciatic pain, which is very common to have sciatic pain, very uncommon to have a sciatic notch hernia as a cause of the pain. So the rare hernias are one, you can have lower back, lumbar hernias, very, very uncommon. Obturator hernia, pretty uncommon. All of these like rare hernias, a pyramidal hernia, it's in the over the pubis, that can be another problem. The others are the groin. The groin is very complex. The pelvis in general is complex. You have nerves, you have sexual function, you have various types of muscles. Plus, you got the genitourinary system for urine. You have the GI system for the rectum and anus. And then you have the sexual system in both men and women. Then you have the musculoskeletal system with the pubic bone and the sacrum and the SI joint and the coccyx. All of those involve orthopedic surgeon, gynecologist, pain management specialist, spine surgeon, urologist, GI doctor, general surgeon, so colorectal surgeon. So all of those areas can have overlapping symptoms due to a non-hernia diagnosis or a hernia diagnosis. So I think chronic pelvic pain and groin pain in general is very difficult. And then diagnosing like a really rare hernia, because you don't know what you don't know. And so if you don't know that there's such a thing called a Petit's hernia or a um, Grenfeld's hernia, which are these two rare lumbar hernias, and the patient's got lower back pain, and if they're not super thin, you're not going to be able to feel these hernias, then they may never get these diagnoses, or it'll take, a decade or so. Or if you don't know that women present differently than men, and you have a situation where you just allow women to have chronic pain, just give them narcotics, which is a very common situation, then then you have a situation where you have decades of chronic pain, and they don't have sex, and they don't have children, and they don't they lose their spouse, and um they can't keep down a job, all because there was misdiagnosis. And what really irks me, though, going back to today's topic, what really irks me is not so much the difficult ones, right? The difficult ones where no one knows what's going on. I just got a referral. I got a phone call before this. There's a doctor who called me and says, I heard that you actually enjoy solving problems. I said, yeah. I said, well, I have this patient. He's actually a colleague. He's a doctor, and he's got this medical problem no one can figure out. And it's been plaguing him for years. So would you mind seeing him? By the way, it's not a hernia. It's not a hernia at all. It's like an abdominal issue. And I said, yeah, for sure. Absolutely. Why not? I'll try and figure it out. My point is, those, the zebras, I can understand. But when you have a situation when you have a diagnosis, it's made. You literally had the patient see a specialist, let's say me, hernia specialist. And the hernia specialist who does this for a living diagnoses the problem. And you're trying to disprove the specialist by showing her all these non-specialists who disagree. That really irks me, because there's a potential to cure this patient. And I have the patient eager to have the surgery, but also hesitant because their medical doctor is claiming that I'm incorrect, and I may hurt him. He has so many patients with mesh problems. By the way, doctor, non-believer, if you have so many patients that you know with mesh problems, complications, you should send them to me so I can fix them. My success rate's pretty good. It's been published. So, why are you hesitant to trust a colleague of yours? And yet at the same time, you're not offering any treatment or to your patient. These non-believers are really working, because I'm a very logical person. I'm a Scorpio, so people understand, like, I'm like very logical, which means sometimes, you know, it really bothers me when people are very emotional about things, because I'm like, well, where's the logic in that? So if I'm giving you 2 + 2 = 4, and you're like, yeah, but is it really 4? I mean, do we really know that it's 4? Like, who told you it's 4? I talked to 5 other people, and they didn't believe 2 + 2 = 4. And I'm like, literally, I'm a math expert. I'm telling you 2 + 2 is 4. And it just bothers me that they don't believe it. And I don't think it's because I'm female. I think it's truly that it's not that they don't believe me because of, like, me. I think they just truly have never been exposed to a situation where there's like new information since he was a medical student. I don't know. Whatever suggestion you guys have, I'm happy to hear about it. Okay, next question. While groin disruption is more common in athletes, is it impossible for a non-athlete to disrupt the pubic plate by lifting something too heavy with poor form using a deadlift technique rather than bending knees? Yeah, it's pretty much impossible. You need you need to have okay, so what is a disruption? You have a muscle attached to a bone. If your muscle is so strong, excuse me, if your muscle is so strong that when it was contracted, it pulled off the bone and pulled some bone off of it, or it tore, then then that's athletic level. If you're not an athlete, how are you going to disrupt that? How are you going to tear? Okay, Incredible Hulk, right? You guys all remember Incredible Hulk? Incredible Hulk, he, when he got pissed off, he was like a normal man. And then when he got irked by something, he would just get so pissed off. And then he would turn green. He would gain all these humongous muscles. And then his shirt would tear. But let me tell you, if you're not the Incredible Hulk, you can't tear your shirt. It's really hard to, if you ever try to tear a shirt apart, you have to tear through it. Like, it's really hard. So an athletic disruption is a similar situation. If you're just a normal bodied person, it's going to be very hard to tear your shirt. You have to be the Incredible Hulk or Lou Ferrigno to be able to tear a shirt. And I'm sure they gave him a shirt that's terrible, by the way. And by terrible, I mean tearable, like able to be torn. That's my point, is I've had so many people, I'll give you an example. The sports hernia type patient that I had last week. She had a tear in her fascia with a nerve going through it. Now, classically, that's a sports hernia, but she had surgery there before. So technically, that tear was a disruption of her surgical repair, not a athletic injury. Now, we'll still call it a sports hernia or sportsman hernia. It's really not. Because we don't really have, we have other like pelvic, it wasn't pelvic plate disruption. A, it was a tear of the external oblique fascia. Usually I see it in gymnasts, ice skaters, uh, soccer players, and so on. Not in a lady who is, in her 70s. So basically, don't let people, because they don't know any better, tell you you have a sports hernia when you don't even are involved in sports. All you have is a hernia that doesn't have an obvious bulge, because it's either a direct hernia, because it's just a weakness, or it's a small indirect inguinal hernia. And classically, that's a dull, achy pain when you stand, it's worse, better when you lie flat, etc. That's usually not the situation with sports injuries. They're usually not better when you're lying flat. If you rest, they're better, but like specifically lying flat is not a thing with most sports hernias. So that's kind of my 2 cents about it. Let's go to the next question. Is that is that of a ventral hernia always an obvious diagnosis? Oh, is a diagnosis of a ventral hernia always obvious? Maybe that's the better way to put it. Yes and no. So there's types of ventral hernias, also called Spigelian hernias, which are not full thickness hernias. We had a whole episode on Spigelian hernias, I believe. So Spigelian hernia is a hernia through the obliques. There's three layers of obliques. The internal oblique, external oblique, external oblique, internal oblique, and transversus abdominis. And if you have a hernia through the transversus abdominis and the internal oblique, but the external oblique is preserved, that is a Spigelian hernia. Those hernias are usually hard to diagnose because they're not obvious. They just may cause pain or a very slight fullness, not an actual bulge. And they're often missed on imaging because people misread the imaging. Another hernia, very often misdiagnosed until you go in there surgically. Arcuate line hernia, more commonly seen in women, most commonly in someone who's had a hysterectomy or C-section. uh, in open fashion where they do a fan steel incision. The way that they close it, it can disrupt the arcuate line. And then you can get what's called an arcuate line hernia. If you're lucky on imaging, you'll see bowel that kind of falls into the space between the rectus muscle and the posterior rectus sheath. There should be no herniation there. I recently treated one of those about a month ago. It's laparoscopic. You don't necessarily need mesh for these. You just close off the space. Um, Typically uncommon ventral hernia and hard to diagnose. There are a couple of diaphragmatic hernias that are hard to diagnose. Um, what else is a ventral hernia that's hard to diagnose? Most of them are pretty easy. The incisional hernias are very easy usually, because you had an incision, and so if you have bulging or pain in the area, you should always think incisional hernia before anything else. Is it necessary for a surgeon to know whether an inguinal hernia is direct or indirect before laparoscopic surgery? Or do they find out during the surgery? With bilateral inguinal hernias, are they usually both either indirect or direct? Do ultrasound reports usually indicate the type of inguinal hernia? Great questions. Okay, I'll do one at a time. Um, it would be helpful to know if you have a direct or indirect inguinal hernia before surgery because direct hernias tend not to do as well as indirect for tissue repairs, so open non-mesh repairs. It doesn't really matter for open mesh repairs if it's direct or indirect. For laparoscopic repairs, if they're both, if the either hernia is a small to medium size, it usually doesn't matter if it's direct or indirect. I personally prefer to change my technique away from laparoscopy if it's a really big direct inguinal hernia, because I feel like it's not as good of a repair as an open repair or maybe even a robotic repair. Um, but it's perfectly fine and common for a surgeon to figure out if it's a direct or indirect during the surgery. And it's often difficult. The ultrasound images and reports usually do not mention direct or indirect because the radiologists usually do not know what the difference is themselves. And it's hard for them to differentiate, and there's no standard by which they need to follow to differentiate one versus the other. For bilateral inguinal hernias, you can have a direct on one side, indirect on the other, or they could be similar. Most patients are symmetric. So if you have a direct on one side, expect a direct on the other. If you have an indirect on one side, expect an indirect on the other, typically. But it's so random, like uh it doesn't necessarily mean that you're going to be symmetric in all patients. There's no rule about that. So I hope that's really helpful for you. Let's go to the next question. Uh, can a hernia, hold on. Can a hernia manifest with symptoms that do not include bulging or pain and still be worthy of prompt surgical attention? The only hernia, well, there's a couple. The main hernia that can have no symptoms, no pain, no bulging, and should still also be repaired is a femoral hernia. A femoral hernia is one of the deadliest of all hernias, because if you do show up in the emergency room with incarceration, strangulation, need for bowel surgery, you have a 5% risk of dying from that admission. So it's a serious problem, mostly because people don't know they have a hernia. There is no bulging, there is no pain until a loop of intestine gets stuck in it, and then you end up in the emergency room. Another similar story is with the obturator hernia. Those are even more rare than a femoral hernia. An obturator hernia classically is seen in a very thin, cachected, constipated patient, usually elderly, usually nursing home patient. That's like the classic situation. Doesn't have to be, um, but it's more often in thin people than robust people, because the obturator space already has a muscle there, so your muscle needs to kind of thin out and to accommodate for this herniation usually. So yes, an obturator hernia also can be one of those where you never knew you had a hernia. Classically, the patient shows up with a bowel obstruction, and the majority of bowel obstructions are in people who've had surgery before, but let's say this patient's never had surgery. So an obturator hernia or femoral hernia should be, or any hernia, should be in the differential diagnosis of someone who shows up to the hospital with a bowel obstruction. And oftentimes they never even knew they had a hernia. So that's where imaging is very important. Um, Maybe a sciatic notch hernia of the different pelvic hernias. Uh, you may not have bulging or pain, but they do usually involve intestine. There's not much fat to be in the area, and therefore what can happen is the patient um, can have an imaging finding, no bulge, maybe some pain, and then there's bowel in there. So if bowel is involved, we usually recommend surgery, even if it's asymptomatic. Does pain at rest, but not after physical activity, always exclude a hernia or its complications? That is a great question. So pain at rest, but not after physical activity. I would say that is typically not a hernia. Pain at rest, but not after physical activity. I'm trying to think. So for those of you who are watching, hernias have pain with physical activity and less likely to have pain at rest. In fact, you may say, yeah, every time I go for a walk, if I'm working a long shift, if I'm at a party, I feel the hernia. But if I lay flat, I'm fine. Hernia goes away, pain goes away. But the reverse, what situation would there be pain at rest, but not after physical activity? I can't imagine one. I would say you're stumping me here. I cannot think of a situation, no matter how rare, where the patient will have pain at rest, but not after physical activity. Yeah, good one. Very, very good one. Let's see. Another question. Why is open repair better for direct hernias? Does data not show less pain with laparoscopic? Um, yeah, I'm not talking about pain, I'm talking about recurrence. So, with a open repair with mesh, you can plicate the direct space. That means you have a redundant thinned out transversalis fascia, and you can sew it in a manner that makes it flat but not tight, and then you place mesh on top of it. With a laparoscopic repair, you can't sew it, you can reduce it and maybe tack it up or sew it up, or robotically you can reduce it and put it up. It's just not as good, I would say, as you would think it would be, and therefore the relative benefit of laparoscopy or robotics is reduced when you have a large, not a small, but a large direct inguinal hernia. Okay. Do MRIs with Valsalva help diagnose femoral hernias or just inguinals? Yes, all hernias. All hernias are benefited from Valsalva. In femoral hernias, you may argue it actually is better because they're so hard to diagnose and they're so small typically. But yeah, all hernias would benefit from Valsalva. So usually whether it's a CAT scan or MRI or ultrasound, we prefer that there's a dynamic component to it where there's bulging, what do you call it? There's a Valsalva or bear down. And that will give a little bit more information than if you didn't. In fact, I have a collection of images that I give at talks where I show before and after, like imaging with and without Valsalva. And it's really helpful to show the difference and why it's important to add that little extra bit. Contrast is not important, right? IV contrast not important in MRI or CAT scan, and yet Valsalva very important. All right, everyone. That was a great hour. Enjoyed speaking with you all. Well, thank you so much for joining me on HerniaTalk Live. Do follow me on Facebook at Dr. Towfigh and also at Beverly Hills Hernia Center. I look forward to seeing you next week. We're going to talk about rare hernias. And if you have any special topics, let me know. I'm going to have a patient come up soon as a guest. And I got some international surgeons as guests, some friends that I met in London who I'm going to bring in as guests. So really very much looking forward to, I would say the next half of the year. Aren't we just past the 50% mark of the year? Yeah. Thanks, everyone. Bye.